In neonatology, the first thing we shall be discussing are the general things, the definitions, terminology, and what does a normal and high-risk newborn mean. So let us begin with the general definitions first. Who is a newborn? A newborn and neonate are the same thing. A neonate is said to be a child who is aged between 0 to 28 days. 0 to 28 days means 0 means the first day of life. So the first 28 days of life is known as the neonatal period. This neonatal period is sometimes subdivided into two parts. You can have the early neonatal period and you can have the late neonatal period. The first 7 days of life are known as the early neonatal period, whereas beyond 7th day till end of 4 weeks is taken to be the late neonatal period. So this is the first thing, that who is a newborn. Newborn, neonate, they are the same thing. Now moving over, let us talk about the classification of newborns. Newborns can be classified in multiple ways. So how do we classify newborns? So classification of newborn baby. First way of classification is based upon the gestational age of the mother. At what age the baby was delivered. So first classification is based upon gestational age at which the newborn was delivered. Based upon gestational age, we can have babies who are term babies or term neonates. Who is a term neonate? If the newborn is born between 37 to less than 42 completed weeks of gestation, we call the newborn as term neonate. 37 to less than 42 week, what does it mean? Because standard textbooks including Williams Obstetrics says that a newborn, if he is born and mother's gestational period is 37 week 0 days to 41 week 6 days, if the child is born in this period, then we call it as a term period or a term neonate. So 37 to less than 42 completed week. A less than sign is often missed by some of the students and it creates problems in MCQs as well as in your vivas. So then we have a preterm neonate. A preterm neonate will be born obviously less than 37 weeks of gestation. And we have a postterm neonate who will be born at or beyond 42 completed weeks of gestation. So this is the first classification, which is based upon gestational age of the baby. The second classification is based upon the birth weight. Whenever the child was born, at the time of birth, what was the weight of the child? It does not take the term period or preterm period into consideration. For that, you need to first understand what is the normal birth weight of a newborn. So on the side, I am writing a point. What is the normal birth weight of a newborn? Normal birth weight of a newborn is defined by World Health Organization as weight range between 2.5 to 3.99 kilogram. This has been defined by World Health Organization. Irrespective of gestational age, whether baby is term, preterm, postterm, if the weight is between 2.5 to 3.99, we will call it as a normal birth weight. And if the question asks you what is the normal birth weight what is the average normal birth weight in India? Latest edition, OP Ghai 9th edition says it is 2.9 kilograms. Because average will always be a single value. So these are the two normal things that you need to remember, and they can be asked as a fact-based MCQ. They are already known viva questions. So normal birth weight range and average birth weight in India. So based upon this definition, this consideration, newborns are subdivided into multiple subtypes based upon kitna birth weight hai. If the birth weight is between 2.5 to 3.99, it will be a normal birth weight, right? If the birth weight is less than 2.5 kilogram, they are called as low birth weight child. So low birth weight newborn, in short written as LBW newborn, is one where the birth weight is less than 2.5 kilogram. This is the first category. Second is very low birth weight, in short written as VLBW, when the birth weight is less than 1.5 kilograms. Third category is extremely low birth weight, ELBW, when the birth weight is less than 1 kilograms. All these are irrespective of gestational age. And fourth category is macrosomia, large baby, heavy baby, when the birth weight is equal to or more than 4 kilograms, that is defined to be a macrosomic baby. Then there is the third classification. The third classification says that newborns can be classified based upon their birth weight and gestational age when plotted on IUGR charts. What is this classification? This is a very important classification because it takes into account both the birth weight as well as the term, preterm or postterm child. The IUGR charts is the common name. They are originally given by a person known as Lubchenco. So they are also called as Lubchenco's charts, right? So what do? We have charts available for babies. The chart looks something like this. On the x-axis, as you can see here, is the gestational age in weeks. On the y-axis, you have weight plotted in grams and various curves you can see. For this classification, there are two things that you need to look at. The uppermost curve is the 90th centile curve and the lowermost curve is the 10th centile curve. So suppose a newborn comes to you, right? You first see what is the gestational age. Suppose 37 weeks. So you look at 37 weeks, right? Then you take the birth weight of the child and plot where the child lies. After plotting, we will see what is the classification when you plot on this chart. If suppose there is 37 weeks and the child is weighing 2800 grams. So let us try to plot here. 37 weeks, right? 2700 grams. So the child will lie somewhere over here between 26 and 2700. So this is where you will plot. And so where is this child lying? It is between 10th and 90th centile. All those children whose birth weight when plotted on IUGR chart or Lubchenco's chart is between 10th and 90th centile, they are called as appropriate for gestational age. So what is this classification? It says that a child is said to be appropriate for gestational age, in short written as AGA, when the birth weight is between 10th to 90th centile, when you plot on a chart, also written as 10th to 90th percentile. If it lies below 10th centile, the child is called as small for gestational age. So if the weight when it is plotted, it will lie anywhere in the zone which is shown in gray in this, then it will be small for gestational age. So what will be the definition for small for gestational age? Birth weight less than 10th centile. And third will be large for gestational age. Large for gestational age or LGA baby, the term will be used when the birth weight will be above 90th centile or above 90th percentile when plotted on Lubchenco's chart. So this classification takes into account both the gestational age and birth weight, and so it is cumbersome, but it is superior to the other two classifications which we have discussed. And you need to remember, a low birth weight baby may or may not be small for gestational age and vice versa, because these are two separate classification systems. When you are taking absolute numerical value, we are saying low birth weight, very low birth weight, macrosomia. When we are plotting on a chart, then we say appropriate, small and large for gestational age. Now, how MCQs can be asked based upon this Lubchenco's chart classification? Let us take an example so that the concept becomes ingrained in your mind. This is an MCQ example. Look at the question. Neonate was born through normal vaginal delivery at term. His birth weight was 3.8 kg and was plotted on the chart in red as shown in the picture. So this is Lubchenko's chart and they have already plotted the baby's weight here, right? What is the likely diagnosis? Whenever birth weight is plotted on a Lubchenko's chart and it is above 90th centile, the child is called as large for gestational age. And so the answer to this question is B, that is large for gestational age. Why the option is not C? Because what is the definition for macrosomia? Macrosomia word is used when the birth weight is equal to more than 4 kg. That is a separate classification. So this is how questions can be asked. Based upon this, visuals can be asked and you are supposed to answer. Now, even in vivas, sometimes you get stuck up. Examiner asks you, suppose you get a newborn case, examiner will ask you, what is the weight of the child? So you will say, sir, the child was delivered at 40 weeks and weight is 2.9 kg, suppose. So examiner will ask you, is it normal? So you would say, yes, sir, it is normal. He would ask why? Sir, because normal range is 2.5 to 3.99. This child lies in that range. Examiner will be satisfied. But then he will ask you again, is the child appropriate for gestational age? What should be your answer? You will not say, sir, it is appropriate. No. Unless you have plotted on Lubchenko's chart, you cannot comment. So you would say, sir, child might be appropriate for gestational age, but to tell whether it is appropriate or not, I need to plot on Lubchenko's chart. Immediately you will get passing numbers because the examiner will know that your concepts are crystal clear. The purpose of me telling you this example is you understand what these different classification systems mean and how they can be interpreted or their interpretation can be asked in MCQ entrance exam. With this classification in mind, we move towards the next topic. The next topic is related to these definitions, these high-risk newborns that we discussed. It is small for gestational age and IUGR. So small for gestational age and IUGR are synonymously used, but they are not the same. Small for gestational age, we have just discussed, birth weight less than 10th centile. So the first thing that you need to know that they are not the same. They are not the same, right? Some SGAs are small for gestational age without any reason. They do not have any abnormality other than less birth weight. And why do they have less birth weight? Because their parents had less birth weight when they were kids. Sometimes low birth weight runs in the family. The child is otherwise healthy. Such babies, when you plot on Lubchenko's chart, they will be below 10th centile. But they will not be IUGR because they have developed normally according to their own genetic pattern. These babies which are SGA but not IUGR are called as constitutional IgA, constitutional SGA. The term used is constitutional SGA. So constitutional SGA is no IUGR in the patient. But these are found to be, usually they are less in number. More commonly, majority of them, they are synonymously used, and so majority of SGA babies are also found to have IUGR. And these are the ones where we use both the terms simultaneously. What is IUGR? IUGR stands for intrauterine growth restriction. Intrauterine growth restriction is a clinical term. It is a clinical term. It is not a technical term. It is a clinical term. When do you say IUGR? Whenever the child is SGA along with clinical features of decreased nutrition, which may happen even in utero. So what are these features? The child will have loose skin folds. The child will have a monkey facies. We are talking about newborns, right? the child will have a thin umbilical cord and the head circumference will exceed chest circumference by more than 3 to 4 centimeters. So when SGA is present with these features, then we call it as IUGR. So IUGR is a clinical term. They are synonymously used, but this is what the exact definition says. So SGA and IUGR, statement-based questions can be asked. So the difference between them, they look similar, they are in certain aspects similar, but they are not the same. And an MCQ point that you need to remember, please add it here. There is a term you find in certain books called as morphological IUGR. What is morphological IUGR? Morphological IUGR is the reverse. The child, the newborn baby has IUGR, but they are not SGA. That is, their birth weight is above 10th centile. So sometimes what may happen is the weight is above 10th centile, but the child has all the features of intrauterine growth restriction, like what we discussed. And even antenatally, when you look at the history, there will be features of reduced uteroplacental flow. Such babies will be called as morphological IUGR. The term morphological IUGR is not favored in pediatrics. You will not find it in pediatric textbooks, but gynecology textbooks mention this word, and so because it is an integrated time of study, so we need to remember these definitions. So since we have started with IUGR, let us talk about the types of IUGR. So what are the two types of IUGR? Intrauterine growth restriction can be divided into two parts. You can have asymmetrical IUGR and symmetrical IUGR. Asymmetrical is very simple. Large head, small body. Symmetrical, small head, small body. Right? So asymmetrical IUGR, what are the points that you need to remember? This occurs usually due to maternal factors. The baby otherwise itself is fine, like preeclampsia, like placental abnormality. So decreased uteroplacental flow will produce asymmetrical IUGR, whereas symmetrical usually occurs due to fetal factors. The fetus itself is diseased and not growing. For example, torch infection. So if MCQ asks you which type of IUGR will be seen in congenital rubella, the answer will be symmetrical IUGR, right? Because it is associated with fetal factors. In asymmetrical IUGR, there is CNS sparing. CNS sparing means the CNS remains fine. CNS sparing is seen, so the head grows normally. That is why the head is larger in size. It is not larger, it is actually normal in size. The other part of the body is shrunken. Whereas symmetrical IUGR, there is no CNS sparing. In asymmetrical IUGR, the third thing that you need to remember, the cell size is less, but number is normal. In symmetrical IUGR, the cell size and number both are low, and they are significantly low. And finally, because asymmetrical IUGR, they look to be dramatic, but they have a good prognosis. They can catch up later in life because the CNS is intact. Symmetrical IUGR usually have an unfavorable or poor prognosis. Unfavorable or poor prognosis. And to distinguish between the two, we use a index called as ponderal index. So what is ponderal index? Ponderal index is a calculation which is based upon weight and length of the child. So ponderal index formula is weight in grams divided by cube of length in centimeters multiplied by 100. This is how you calculate ponderal index. When you calculate ponderal index, there can be two possibilities. Ponderal index is less than 2 and ponderal index is equal to or more than 2. If it is less than 2, this is a thing which is seen in patients with asymmetrical IUGR. Whereas ponderal index equal to or more than 2 is seen in children with symmetrical IUGR. Normally, ponderal index is not calculated in non-IUGR baby, but suppose there is a normal baby and you want to calculate, you calculate it. What value will you expect? A normal baby will be symmetrical for his age because he's normal, right? And so there will be in that value, although it is not done, but if somebody asks you, ponderal index was done in a term normal baby, what value will you expect? You will find it to be equal to or greater than 2. So you can put a star and write the MCQ point. In appropriate for gestational age babies who are non-IUGR, if ponderal index is calculated, the value obtained is equal to or more than 2. So this is your MCQ. So we discussed about the IUGR babies briefly. Next we move towards the large for gestational age babies. Large for gestational age, the definition we have already done. They have birth weight more than 90th centile when plotted on Lubchenco's chart. What are the common causes of large for gestational age babies? So what are the common causes? The common causes include constitutional reasons. The whole family is huge in size since beginning. Father, mother, they also were large for gestational age in their times. Their grandfather, grandmothers, paternal, maternal, everybody was like that. So the child will also be like that. So that is constitutional reason. That there is no other abnormality. Secondly, it occurs in infant of diabetic mothers. This is very important, and this is also NEET PG MCQ. 2 years back it was asked. Infant of diabetic mothers, in bracket you can write most common pathological cause of LGA babies. Third, it can occur in a syndrome called as Soto's syndrome. Soto's syndrome is also called as cerebral gigantism. Fourth, it can occur in a syndrome called as Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome has been discussed in details in the malignancy part in this app, where I have talked about Wilms tumor. But if you want to summarize, you can simply summarize Beckwith-Wiedemann syndrome as a combination of multiple factors. These children have hemihypertrophy, that is, one half of their body is larger than the other half. They have omphalocele, which is an anterior abdominal wall defect. They have macroglossia, that is large tongue, and they have increased risk of Wilms tumor. These are the 4 important points that you need to know regarding Beckwith-Wiedemann syndrome. So these are the common causes of large for gestational age babies. So we are done with the definitions and the key features and classification scenarios for various newborn babies. After this, we move to the next thing, the next topic, which is related to assessment of gestational age in newborns. Now, assessment of gestational age, how do you do it clinically? If you have the gynecological, the obstetric records, you can have a look and know this is the gestational age. Suppose you don't have it. We are pediatrician, we deal only with the kid, not with the records. So I have a kid in front of me. I don't know his gestational age. I don't have the mother or any record. How would I, by examining, tell what is the gestational age, whether it is term, preterm or post-term? That is called as assessment of gestational age. And assessment of gestational age is done by a clinical method called as expanded new Ballard score. So what is the name of the method? Expanded new Ballard score. This is AIMS MCQ, already asked some years back. Which among the following is assessment method for calculating gestational age clinically? What is expanded new Ballard score? Details you will be reading are needed in your when you do MD in pediatrics. But for entrance exam, for NEET PG, next exam, FMG exam, you need to know certain basics. So for assessment of gestational age, we take two criteria. There are two set of criteria which are taken in this method. The two set of criteria include the visual examination of the child, also called as clinical examination or clinical appearance, how the child looks. And second, we look at the neuromuscular examination. These two parameters are used. It can be performed in children ranging from 20 to 44 weeks. So which gestational age it can be applied? Very broad range, ranging from 20 to 44 weeks. What is the accuracy of this new Ballard score? Accuracy, according to O.P. Ghai, according to American Academy of Pediatrics, it is plus minus 1 week. So it can fairly tell about gestational age with an accuracy of plus minus 1 week. Then what is the least score? The least score, there is a scoring method. First, we check for the appearance. There are scores given for that. Then we check for neuromuscular examination, calculate score for that. The least score you can find is minus 10, which corresponds to an age of 20 weeks. And the maximum score which you can find in these children is plus 50, which corresponds to a gestational age of 44 weeks. And you can have a look how the charts look like. As you can see, on one side we look at the neuromuscular maturity or neuromuscular examination, and we have the physical examination or physical maturity. So two set of criteria, the clinical appearance and the neuromuscular examination we are taking into consideration. Various kinds of parameters are there. Various kinds of parameters are there in both the categories. You don't need to remember it by heart. Even in post-graduation or when you prepare for super specialty, you have these charts in front of you. All you do is, you have a kid in front of you, you check for each parameter and keep on writing what is the score for that parameter. In the end, you combine all the scores and look at this chart. Look at this maturity rating. If it is minus 10, the child is 20 weeks of gestational age. If it is minus 5, it is 22. If it is 0, it is 24. It is 5, it is 26, and so on. So this is how we check for. Now, how questions can be asked? There can be one-liners, which I have already mentioned. They can show you this physical photograph, these two tables, and ask, what is this method known as? The answer will be expanded new Ballard score, useful for gestational age, right? That is all you need to do in this topic. Next, we move to the preterm babies. So preterm babies is a hot, important topic. A lot of questions are asked on preterm babies. So we'll be focusing on, first of all, how to identify. What are preterm? Any child born less than 37 weeks. If you don't know gestational age, if you don't know the expanded Ballard score, still clinically, how will you identify? So the first thing that we will discuss is how to identify. Very frequently asked in entrance exam. Preterm babies are found to have a birth weight less than 2.5 kilogram and birth length less than 47 centimeters. Okay. Second, they have a thin, shiny skin. Third, their breast nodule size is less than 5 millimeters. Fourth, their tone, that overall tone of the body is found to be less. This decreased tone manifests in two things. One, they have a extended posture. Normally, you know that term neonates are flexed, right? Preterm neonates will be extended somewhat. So they have an extended posture. Secondly, there is a test called as scarf sign that we perform. When you perform scarf sign, because the tone of the body is less, you can extend the elbow. So the elbow can be extended beyond the midline of the body. What does it mean? What we do is, you have a newborn lying there, right? You will hold the elbow. Now this is a newborn. I am a newborn, right? somebody will hold my elbow and slowly bring it across the midline. If it is a term neonate, you will not be able to bring, this is the elbow, right? You cannot bring it beyond the midline. You cannot do that because newborn has an inherent tone. But in a preterm child, this elbow can be crossed across the midline. That is called as elbow crossing the midline, scarf sign positive for preterm baby. So scarf sign, if it is an indirect indicator of tone of the child. If it crosses midline, the child is premature. Very useful clue. You can also practice if you go to the clinics someday, or if you are an intern. How MCQ can be asked? They can show you a picture like this and they will ask you, look at this picture and tell which sign is being performed. So this is scarf sign which is being performed. Second MCQ they can ask you, look at this child and tell whether he is term or preterm. Although it is difficult to say, but from where I can look, the elbow seems to be crossing the midline, right? And they will mention this maneuver was performed and the elbow was crossing the midline as shown in the picture. What is the likely diagnosis? The likely diagnosis will be premature child. That is all you can say. You cannot tell the gestational age correctly, but you can say term or preterm. If the question says this procedure was performed, elbow did not cross midline, think of a near term or term baby. So this scarf sign is important and can be asked in exam. Next point, to differentiate term and preterm babies. Look at the ear of the child. Preterm babies, the ear cartilage is not properly developed and so it shows a poor elastic recoil. So ear in preterm babies, they have a deficient cartilage in the ear, in the pinna, and so it shows a poor elastic recoil. Poor elastic recoil. What does it mean? You have your ear. Try to fold it like this. I folded my ear. I leave it. Immediately comes back to its normal place. That is known as elastic recoil, right? Now you have a premature child. You fold the newborn's ear. It will get folded up. Once you leave it, it will remain folded for some time. That is called as poor elastic recoil because the cartilage is not properly developed. Another useful clue you can do on the bedside. Then other things which you can look for, these children, preterm babies, will have abundant lanugo. What is lanugo? Lanugo refers to fine fetal hair. They are non-pigmented hair which are present all over the body and they are only absent on palms and soles. So lanugo is fetal hair. What is a preterm child? Fetus who has been born premature. So they will have abundant lanugo. These children have little to absent vernix caseosa. What is vernix caseosa? It is a cheesy material which is derived from precipitation of proteins in the amniotic fluid. If you have attended a delivery, you will find that certain term and post-term babies, they have a cheesy material sticking when they are born. That dries off and falls off in a few days, so it does not need to be removed actively. Vernix caseosa is nature's way. Vernix caseosa, nature knows now the baby's term, he is going to be born. So vernix caseosa serves two functions. First, it acts as a lubricant for the baby for its passage through the birth canal so that the child does not suffer friction. Secondly, it also plays a role in thermoregulation by not allowing the evaporation losses to occur in the child. But vernix caseosa, nature says it should come when the baby is term. Preterm baby, it will not be there because he is born prematurely. And so the babies will have lot of lanugo, fetal hair, but no vernix caseosa. Two things where students go wrong. Do not mix them up. If you look at the sole of the foot, you will find that sole of the foot, there are absent skin creases in preterm babies. Or even if they are present only in the upper half or upper one-third of the foot. If I have to show you pictorially, look at this. Can you see the soles are entirely smooth? And look at this picture. The soles have prominent skin creases. So these are the soles of a preterm baby and these are the soles of a term baby. Term babies have prominent creases on the sole of foot. Preterm babies have no skin creases or very mildly conspicuous skin creases. And even if they are present only in the upper 1/3 of the foot. And finally, we look at genitalia. Male babies will have undescended testes and female babies may have widely separated labia majora. So these are the clinical findings which will be helpful in identifying a preterm baby. Questions can be asked. Vivas, they are often asked. How many questions have been asked? If I go back from what I have seen, at least 3 to 4 MCQs in past few years have been asked based upon these points, and that is why I have spent considerable time trying to explain these points to you. The time I spend on a topic is directly proportional to its importance in being asked. Now moving over from the preterm babies, how will you identify, to the problems in preterm babies. So the next is problems in preterm neonates. What are the conditions which are more common in preterm babies compared to term babies? Firstly, they have increased risk of asphyxia. What is asphyxia? Decreased oxygen supply leading to hypoxic damage, which will cause damage to the brain and other organ systems. Preterm baby is not ready to perform an independent function, so obviously there will be problems in the tone, there will be problems in respiration, respiratory drive, there will be problems in lung maturity. So a combination of these can produce asphyxia in the child. Secondly, preterm babies are found to have higher risk of hypoglycemia. Why? When you and me, we fast for some time, glucose level in the blood is maintained by glycogen content in the liver. Problem with preterm is, preterm babies have little to absent glycogen reserves, and so even if a single feed is missed, they will be prone to hypoglycemia. Term babies, on the other hand, nature ensures they have sufficient glycogen, so they do not easily develop hypoglycemia. So you can write in bracket, preterm babies have hypoglycemia because of low glycogen reserves. And this is your MCQ point asked some years back. Third thing, preterm babies are found to have increased risk of kernicterus. What is kernicterus? Damage to basal ganglia and other parts of the brain due to unconjugated hyperbilirubinemia. There are multiple reasons why kernicterus happens. Details of kernicterus I have discussed in the module on neonatal jaundice, but in bracket you can remember, because preterm babies, they have poorly developed blood-brain barrier. So unconjugated bilirubin can easily cross the blood-brain barrier and cause damage to the brain. Fourth, preterm babies have a higher incidence of a congenital heart disease known as patent ductus arteriosus. The receptors for closing PDA are not fully developed in preterm babies. Fifth problem, they have increased risk of inflammatory disorder, which we have discussed in details, called as necrotizing enterocolitis. It is an inflammatory condition of the gut. So NEC is more common in preterm than term babies. Sixth, they have a higher risk of respiratory disorders. What are the respiratory disorders which have a higher risk? They have increased risk of HMD or RDS, which occurs due to surfactant deficiency. The lungs are not mature, so they tend to collapse. And secondly, they have an increased risk of bronchopulmonary dysplasia. Bronchopulmonary dysplasia occurs in infancy, beyond the neonatal period. So BPD risk is also high. Seventh, they have increased risk of intraventricular hemorrhage in the brain. Intraventricular hemorrhage, IVH, in the brain. Now, why preterm babies have intraventricular hemorrhage? To understand this, you need to know that when the child is in utero, around 24 weeks of gestation, a loose network of capillaries develop in the brain. That loose network of capillaries develops around the ventricles in the periventricular white matter. It is called as germinal matrix. Germinal matrix has these poorly defined large fragile capillaries in the fetus. Now, these germinal matrix capillaries tend to get resolved. They are removed from the system by 34 weeks, right? So when a term baby is born, there is no germinal matrix fragile vessels, and so there will be less risk of bleeding from that. Imagine a baby who's born preterm at 28 weeks, right? There was trivial trauma, or you gave a rapid bolus of some fluid. What will happen? Those fragile capillaries in germinal matrix will rupture, and they will cause that bleeding to reach the ventricular region that will produce intraventricular hemorrhage. So you can write in bracket, IVH occurs in preterm babies because of germinal matrix which is prone to hemorrhage or prone to bleeding due to fragile thin-walled capillaries. And germinal matrix or IVH risk is maximal in what age? Between 24 to 34 weeks. Beyond 34 weeks, IVH is usually not seen. Then these children also have increased risk of apnea of prematurity. What is apnea of prematurity? Apnea means absence of breathing. Newborn forgets to breathe. The respiratory drive from pre-Bodzinger complex does not come. The respiratory center. That is apnea of prematurity. They have a problem called as retinopathy of prematurity. The details of retinopathy of prematurity have been discussed in a separate module. You can have a look at it later. Retinopathy of prematurity is a condition where the fragile capillaries, when in the retina, in preterm babies, when it is exposed to high oxygen concentration, there is damage followed by neovascularization, which causes blindness in the child. And 10th, they have problems of anemia and osteopenia, that is decreased hemoglobin, decreased bone density of prematurity. So these are the common problems you find in children with preterm. How questions can be asked? You can be asked about which of the following is a problem in preterm. Question can ask you, all of the following are seen in preterm except, the odd one out will be your answer. And third, they can ask you particular reason for a specific problem. The important reasons I have already explained and mentioned. The things you need to remember are this, and this, because they have been already asked in some form in the previous entrance exams. So these are the problems in preterm. Next we move to the problems in post-term babies, and as you can see, this is a post-term baby. Why am I saying it is a term or post-term baby? Because these children are found to have abundant vernix caseosa. So first let us talk about the post-term babies. What are post-term babies? They are born at or beyond 42 weeks of gestation, right? What are the features you will find? How will you identify them? Firstly, they are found to be hairy in nature. So they have a lot of body hair. Secondly, they may show some desquamation of the skin. So peeling of the skin can normally occur. Thirdly, they have abundant vernix caseosa, the cheesy material which I told, as you can see in this child. Can you see this vernix caseosa which is sticking to the body? Interns, first year residents, they are very fond of trying to clean up the baby by removing it. Don't do it. It will cause unnecessary damage to the skin. Let it dry, it will soon flake off, fall off. It's nature's thing. So don't interfere with nature. Then they are found to have long nails. They have long, thin nails, and sometimes these nails need to be cut. There are special nail cutters available for these babies because they can actually cause damage to their own eyes. It has been shown that it has occurred in my clinical practice. I have seen a baby who had a lot of scratches over his face, and there was a scratch very close to the eyes also. Parents were skeptic. They brought the child saying this child was born some days back. There is a lot of these things on the face. And I asked the parents, look at the nails of the child, you need to cut them. So parents were not convinced, how can you cut nails in the child? So obviously I cut them. It's not something you can ask the parents to do in a very young child, but long nails are one of the clues. In one of the old DNB CET questions, this was asked as a MCQ option. So remember, long nails are a feature of post-term babies. And they are also found to have loose skin folds. Loose skin folds are also found to be there in some preterm babies. What are the problems which are more common in post-term babies? First, post-term babies have higher risk of meconium aspiration syndrome. Meconium aspiration risk is not increased in preterm, but it is increased in post-term babies, particularly if they are IUGR, because meconium will be passed in the baby in utero, and so they can aspirate, increasing the risk. They have increased risk of asphyxia because if the weight becomes too much, the placental circulation fails to match up with that. Thirdly, they have increased risk of transient tachypnea of newborn, the topic we have discussed will discuss in respiratory disorders. They have increased risk of polycythemia. And finally, they have increased risk of hypocalcemia. Hypocalcemia. So this is regarding the problems that you find in post-term newborns. But problems in post-term are not very frequently asked compared to problems in preterm. And remember, if question says which problem is not seen in preterm babies but common in post-term babies and very common in IUGR post-term babies, the problem is meconium aspiration syndrome. Because whenever there is intrauterine stress, there will be release of factors like motilin. They will cause the release, they will increase gastric motility, they will cause premature, they will cause intrauterine passage of meconium. Baby may aspirate, leading to meconium aspiration syndrome. So in bracket you can write, because in utero, any stress to the baby can increase the levels of motilin, which will increase intrauterine meconium passage, which can be aspirated by the baby. MCQ on this has been asked. So it is an MCQ point. I have just given you the explanation for it. Next, we move to some normal neonatal values. So let us talk about the normal neonates. So normal neonatal values that you need to remember. Normal birth weight we have already done, 2.5 to 3.99 kilograms. What is the average length in a normal term neonate? We are talking about term because unless specified, we are talking about term. So average length is around 50 centimeters. The average head circumference or occipitofrontal circumference is 33 to 35 centimeters. The average chest circumference is 3 centimeter less, so it is 30 to 33 centimeters. 30 to 32 centimeters. Then you have upper segment to lower segment ratio. At birth, it is 1.7:1 to 1.9:1. What is the normal heart rate in a newborn at birth? It is 110 to 160 beats per minute. Normal respiratory rate, it is 40 to 60 per minute. Some books give a value of 30 to 60 per minute. They are identical, just different references. What is the normal blood volume? Normal blood volume. If I ask what is the blood volume in adult, you and me, you will say 5 to 6 liter. But in a child, it depends upon the weight of the child. Normal blood volume in term baby is given by the formula 80 to 90 ml per kilogram. Whereas in preterm, it is 90 to 100 ml per kilogram. Prima facie, it looks like preterm have more blood. But it is only a relative thing because preterm have less weight also, right? So, per body weight, yes, preterm have slightly more blood volume as compared to term babies. Calculation of blood volume in a baby can be asked as a potential numerical MCQ in your exam. So, you must remember this value. What is the value for normal blood volume in a neonate? So, these are some of the normal neonatal values that you need to remember. Lastly, one thing we can write additionally, what is the normal body temperature? The normal body temperature in newborn is always measured in axilla, and it is given between 36.5 to 37.5 degrees Celsius. So these are the normal neonatal values. After this, we move towards normal neonatal care. These values, these things which I am mentioning, they look like one-liners. They are one-liners, but they are often missed by students when they are reading their textbook from Ghai or from Nelson, and they are asked as one-liners in your exams. So I've taken some selected things from the latest resources. Normal neonatal care. First of all, before delivery happens, what should be the normal delivery room temperature? So what is the normal delivery room temperature? Different books say different thing. This is AIMS MCQ already asked in the past. The normal delivery room temperature is, if you are given a single value, it is 25 degrees Celsius. If you are given a range which happened in the exam, the range is 25 to 28 degrees Celsius. Because according to AIMS Protocol 2019, preterm babies are more comfortable at slightly higher temperature of 26 to 27. And so the range is always 25 to 28. Term baby, 25 is fine. Preterm baby, you can take a higher range. So range is 25 to 28. Whenever a child is born, you should do cord clamping. But what should be the cord clamping time? Early or late? So in a term neonate, we always go in for delayed cord clamping. So delayed cord clamping is recommended in all stable, the word is stable, term as well as preterm babies. Stable term and stable preterm babies. And how much do we delay? By at least 30 seconds. If they ask the range, it can be up to 60 seconds also. So what are the advantages of delayed cord clamping? The advantages include, it decreases the risk of, this delayed cord clamping decreases the risk of anemia in the child. It decreases the risk of shock in the child by restoring intravascular volume. It decreases the risk of intraventricular hemorrhage in preterm babies. And although not proven, some of the studies say it also decreases the risk of necrotizing enterocolitis in preterm babies. However, there is a disadvantage that it increases the risk of neonatal jaundice slightly. But overall, wherever possible, delayed cord clamping by 30 seconds is recommended. The practical point to note is, if the child is not breathing or if the child has asphyxia, you don't wait for 30 seconds ki sir has told 30 seconds so we will delay cord clamping. No, there you immediately cut and start with the resuscitation as early as possible. So delayed cord clamping need not be given any consideration when the child is having asphyxia. The next point is, whenever a child is born, you need to ensure 5 cleans, also called as 5 C's. What are these 5 C's? They include clean hands, right? Clean surface, clean blade, clean umbilical cord clamp. Clamp is of umbilical cord, the one you put on the umbilical cord before cutting it. And fifth is clean cord, that is cord care. So these are the 5 cleans that you need to remember. Another important thing, whenever a child is born, you start breastfeeding. When breastfeeding should be started? As early as possible, whenever the child and mother are comfortable, and practically within 1 hour of birth, it has to be started. So practically within 1 hour of birth, it has to be given. Then all babies at delivery, at the time of birth, they receive injection vitamin K. Vitamin K injection, according to Government of India, is mandatory to all institutional deliveries. It is given intramuscularly in intramuscularly in anterolateral thigh. What is the dose? The dose is 1 milligram, single dose. However, if the weight of the child, if birth weight is less than 1 kg, the dose becomes half, that is 0.5 milligram dose needs to be given. Vitamin K is of 2 types. It is K1 and K3. OP Ghai says K1 is better than K3. But if K1 is not available, you can always go in for K3. K3 has a risk of hemolysis in G6PD individuals. And why do we give vitamin K? It prevents hemorrhagic disease of newborn. Hemorrhagic disease of newborn is discussed in the miscellaneous parts of this neonatal module. Moving towards the next slide, some more neonatal care things. Newborn should always be put in supine position on his back. Never put the child in prone position. Why? Because if you put newborn in prone position, it increases the risk of sudden infant death syndrome. Death of the child can happen. SIDS, sudden infant death syndrome. So we always put the newborn in a supine position. A normal neonate passes stool as well as urine within 24 hours of birth. What is the normal urine frequency of a newborn? It is 6 to 8 times in 24 hours, but can be less or more depending upon the amount of feed the child is taking. All newborns, they are started on vitamin D supplementation, vitamin D oral drops in a range of 400 international units per day. They all require 400 international units per day. Before discharge of any normal neonate, you should always explain the danger signs. What are the danger signs you will explain to the parents? You would say if the child is having temperature less than 35.5 degrees Celsius or more than 37.5 degrees Celsius, or if the respiratory rate is equal to more than 60 per minute, or if there are chest indrawing in the newborn, or if the newborn shows poor feeding, if the newborn shows seizures or convulsions, or if the newborn is having lethargy. These 6 are considered to be danger signs. The child immediately needs review SOS, that is whenever it is possible. You will explain to the parents if any of these danger signs are present, you must examine the child. However, in high risk individuals, you can plan a normal visit in the next 48 to 72 hours also. And finally, when will you bathe the child? So bathing of the child, remember, you need not bathe the child immediately after birth. So bathing can be postponed till umbilical cord dries and falls off. And when does the umbilical cord normally fall off? It usually falls off around 5th to 6th day of life. So you will ask the parents, so you can do wet sponging of the child till 5th or 6th day. Once the umbilical cord falls off by itself, after that you can bathe the child easily. And ensure the child is fed on demand, adequate feeding is ensured, adequate follow-up is ensured, danger signs are looked out for. You should advise massage of the child. Costly oils are not needed. Mustard oil is certainly not needed. All these ghees and butters, they are not needed. All you need is simple non-irritant oils like coconut oil, which you can use for massaging the child. All this comprises the normal neonatal care. I have selectively gone through and taken out points which are mentioned in GHAI, Nelson and Ames protocol and have a tendency to be asked or have been asked in the. Moving over to some normal neonatal phenomena. There are certain normal neonatal phenomena which do not require any consideration of healthcare visit. Always remember that any newborn who has acrocyanosis, also known as peripheral cyanosis, in first few hours of life, that is considered to be normal. Central cyanosis is always abnormal, but peripheral cyanosis in first few hours can be a normal phenomena. Second, if there is peeling of skin in a postterm baby, that is found to be again a normal phenomenon. Nothing needs to be done. And thirdly, parents will come to you with complaint. Child passes stool every time he feeds. That is abnormal in you and me, not in a newborn. Newborns have a strong gastrocolic reflex. Sometimes when they feed, they pass stool. That is normal. So passing stools each time on feeding, again it is found to be normal phenomena due to gastrocolic reflex being prominent in certain children. So these are all normal neonatal phenomena. MCQ on it has been asked, so that is why I have summarized here. So finally we come to the topic known as KMC. KMC stands for Kangaroo Mother Care. What is kangaroo mother care? It is a special technique which was originally described in Colombia, and it has been found to be very useful for growth of preterm and low birth weight babies in the first few weeks of life. Kangaroo mother care refers to the care of low birth weight and preterm neonates by ensuring direct skin to skin contact between the mother and the baby. Usually mother is the caretaker, so we say kangaroo mother care, but it can be given by other caretakers including father also. So can father give kangaroo mother care? Yes, he can and he should, because taking care of the baby is not only the job of mother, it's the job of the complete family, including especially the father as well. So kangaroo mother care, anybody who's willing and oriented and taught how to give care, there should be direct skin to skin contact between the mother and baby, and you should put a wrap around it so that there is prolonged skin to skin contact. Who are the children who benefit from kangaroo mother care? Kangaroo mother care is indicated in all low birth weight newborns who are born either preterm or even term babies. However, preterm babies are the ones which maximally benefit from kangaroo mother care. And what you should ensure that the weight of the child is equal to or more than 1800 grams. If the weight is less than 1800 grams, you need to wait for a few days before it can be started. You can stop kangaroo mother care if the child is having weight equal to or more than 2500 grams, or if the overall corrected gestational age now exceeds more than 37 weeks. The child was delivered at 32 weeks, you started. Now 5 weeks have crossed for giving kangaroo mother care. Now you can stop that. Kangaroo mother care, what are the advantages? Advantages you already know. It ensures mother to child bonding. The child has decreased chances of hypothermia in the baby, not in the mother, and it increases the milk output in the mother as well. So it ensures adequate feeding in the child as well. All these are advantages. There are, frankly speaking, no disadvantages of kangaroo mother care, and so it is highly recommended in these babies. You can get a photograph like this and they will ask you what is being done. This is kangaroo mother care which is being done. Direct skin to skin contact, and then you bring a cloth to cover both mother and baby together. And finally, you need to know about the components of kangaroo mother care. Components of kangaroo mother care have been asked in NBE based exams and past FMGE exam as well. So components are three. There are three components of kangaroo mother care. First is kangaroo position. Second is kangaroo nutrition. And third is kangaroo discharge. Kangaroo position, direct skin to skin contact with a wrap around. That is known as kangaroo position. Kangaroo nutrition basically means exclusive breastfeeding while doing kangaroo mother care. No other feed should be given. And kangaroo discharge means you discharge the baby on kangaroo mother care, ensuring that the same procedure is followed at home also, and only when the weight exceeds 2500 grams, or if the child is now big and strong enough to wriggle out of kangaroo mother care, then you can consider stopping it. So position, nutrition and discharge are the three traditional components of kangaroo mother care. So this finishes the normal neonates, their terminologies, the high risk babies, their problems, and some points related to kangaroo mother care.